Communications Officer with CPSI, and I'll be your MC for the webinar. I would like to welcome you on behalf of our web host, Tricia Swartz, CPSI Patient Safety Improvement Lead, and our technical host, CPSI Project Coordinator, Gina Peck. Our call today is the fourth in this informative six-part series, building on the third session a month ago. In this discussion, we'll focus on the next key step to inform implementation initiatives, identifying barriers and enablers to implementation. Spot what will help or hinder you on your journey to implementation. While this series is best enjoyed as a whole, you are always welcome to attend any one, several, or all 6 webinars in the series. If you miss a webinar and want to catch up, please know that all are recorded and available on our website the week following their webcast date. It gives me and CPSI inestimable pleasure to introduce our speakers for this webinar, Dr. Justin Presseau and Dr. Andrea Patey. Dr. Presseau has a PhD in psychology from the University of Aberdeen. He's been awarded Early Career Awards from the UK Society for Behavioural Medicine, the International Society of Behavioural Medicine, and the European Health Psychology Society. He's an associate editor for journals Implementation Science and Applied Psychology, Health and Wellbeing. Dr. Presseau is a scientist at the Ottawa Hospital Research Institute and an assistant professor in the School of Epidemiology and Public Health and the School of Psychology at the University of Ottawa. He is the scientific lead for knowledge translation at the Ottawa Methods Centre. Dr. Presseau's research program operates at the intersection between health psychology and implementation science. He draws upon behavior change theories and methods to understand factors that promote and undermine behavior change in healthcare settings. And then he designs and evaluates theory-based strategies for promoting healthcare, professional behavior change to increase best practices and reduce non-evidenced practice in healthcare. Dr. Andrea Patey holds a PhD in health psychology from the City University of London and is a senior clinical research associate within the Centre for Implementation Research at the Ottawa Hospital Research Institute. Dr. Patey's interests in knowledge translation and implementation research include the application of psychological theory and methods to explain and change health professional behaviors across a range of clinical settings. Her interest in behavior change focuses specifically around whether implementation and de-implementation differ, and if interventions to target each should differ. The broad objectives of her research are to promote the delivery of evidence-based healthcare through the development and evaluation of complex behavior change interventions. Dr. Presseau and Dr. Patey will talk for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box or the chat box, and they will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, please connect with us in the chat or question and answer box, and we would be happy to assist. Without further ado, CPSI is delighted to welcome our speakers for today, Drs. Justin Presseau and Andrea Patey.
Thank you so much, Trevor, for that very kind introduction, and thank you to all the attendees for making the time today. Welcome to those of you for whom this might be the first webinar, and welcome back to those that are joining us for the fourth. So let's dive right into it. What we hope to cover over the next 45 minutes or so is, first of all, to bring us up to speed quickly with regards to where we're at in the webinar series. We'll then provide an overview of key frameworks, contemporary frameworks used in implementation science to assist in the identification of barriers and enablers. And then I'll hand over to Dr. Patey, who's going to provide us an in-depth consideration of the theoretical domains framework in particular as one of those key frameworks. And as always, just as a sort of a reminder, our perspective on knowledge translation and implementation science is distinctly a behavioral one, because we argue that the successful implementation of a patient safety program needs the key actors, whether they be patients, the health providers, managers, and or policymakers, probably a combination of those, to change what they do, to change their behaviors, to change their decisions, while recognizing that they're working in complex healthcare environments. But framing our approach in that way, it allows us to draw from the substantial evidence base from within the behavioral sciences around how to understand behavior and behavior change, and how do we support helping people change their behaviors within the healthcare system. And our hope is that in drawing on this through this webinar series might help those of you attending it to potentially draw on this to inform some of your own patient safety programs in hopes that it might increase the likelihood of success. So again, just to situate ourselves, we're in webinar 4 of 6, and we find it useful to frame this webinar. We've tried to frame this webinar within the Ian Graham's Knowledge to Action framework. And so for those of you who are on the second webinar, you'll remember that we focused, Jeremy Grimshaw focused down on the center of the KTA framework in the knowledge creation funnel, so to speak. And the culmination of that process might be a research-based systematic review, like a Cochrane review, or a more practical knowledge product, like a clinical practice guideline, evidence-based clinical practice guideline, or a decision aid to use with patients, or maybe a policy brief. But we also talked about that producing and disseminating those products doesn't necessarily lead to those that are, for whom they're developed, to change what they do. Which led us on to the third webinar, which got us to exit that middle knowledge funnel and into the surrounding action cycle, where we made a point to focus on really on identifying what is the problem implied by trying to implement this knowledge product into practice. And so we talked through whether identifying any evidence of a gap between what the evidence suggests should be done and what is currently being done. We then talked through the importance of clarifying who needs to do what differently in the setting in order for that to be implemented. And then we presented a tool, the Target Action Context Time and Actor, TACTA, as a vehicle for specifying what each of the people involved in the process is doing in their behaviors. And now we might be tempted at this stage to now jump to, now that we know the problem, we know the people involved, what they need to change, that we might jump to the intervention right away. Certainly, I'm sure those of us on the call could easily sit in a room and brainstorm what potential interventions could be applicable in a given setting. But you'll notice farther up the process, there's in selecting and even tailoring interventions, it really depends on knowing what we need to tailor on, so that the solutions that we provide are fit for purpose going forward. Which leads us to this middle ground, this important middle ground of really trying to understand what might or what does help and hinder implementation. In other words, what are the barriers and enablers to using this knowledge, and using that as a vehicle for then selecting the right, ideally the best and the right intervention to address those barriers. So that's what we're going to focus on today. As always, we try to be consistent in having a generalizable case study. So we're focusing again on physician hand hygiene, which for those of you for whom this is the fourth webinar will be utterly familiar with this, but I'll just quickly go through the background here. We know that healthcare-associated infections are a top 10 cause of hospital-related death worldwide, affecting 1 in 10 patients, and that hand hygiene compliance nevertheless remains an international problem, despite being what seems at face value to be a relatively simple behavior. The average compliance rates tend to still hover around the 50% mark. The reasons for why that's the case are remain particularly not well understood. And so we might use this as a basis for talking through this webinar and the points within the frameworks that we're going to present to assume that we want to develop a patient safety initiative to improve physician hand hygiene. This is one of the results of the tool that we walked through in the previous webinar. So this is that Target Action Context Time, TACTA, way of, rather than just calling it hand hygiene, breaking it down into the action specifically, using hand gel, who's involved, the target, in this case patients, for whom and with whom the behaviors performed, where and at what time. And so the question is now, what do we do? So in other words, we've covered step 1, who needs to do what differently. But what are the factors that determine whether or not they do it? What are the barriers and enablers? And so we talked through it, and again, it seems like such a simple behavior compared to possibly other more complex behaviors that some might be involved in, but nevertheless remains an issue worldwide. And we know that there are consistent modifiable factors that influence whether someone engages in any behavior. whether a behavior is performed or not. A lot of those will be intuitive and familiar to those of you on the webinar, things like knowledge and motivation, but many might be less intuitive. And so the advantage of drawing on theory to understand barriers and enablers is that, first of all, it provides us a leg up on factors to focus on. Rather than having to reinvent those factors, we can draw on factors that have been shown previously in the literature. But the other major advantage is that it provides a shared language so that we have a common ground for understanding what the barriers are across different settings so that we can learn from each other, which adds a level of efficiency to the process so that rather than every setting in which we want to implement something, we start from scratch, we can draw on what others have shown using this shared language developed within theory. And from my perspective, one of the key elements of good theory and good theoretical frameworks are that they not only present you with a framework for understanding barriers and enablers, but they provide an opportunity to link those barriers to fit-for-purpose techniques and strategies, which helps in the process of then designing a better suited intervention. So in the 50s, I think, late 50s, a relatively famous psychologist, Kurt Lewin, once said that there's nothing more practical than a good theory. But anyone who sort of dipped their toe into this literature would probably recognize what our friend here on the bottom is saying. But Kurt, which theory model framework should we choose? And indeed, there are dozens, if not hundreds, of different theories that depending on your field of interest, you could draw from, which is not helpful, admittedly. But despite that, within implementation science, one of the really important papers to come out recently highlights the importance of using theory to understand and explain influences of implementation outcomes. So what does that leave us with? It leaves us with tons of theories and not much guidance yet in terms of how do we pick from amongst them, which has led to at least 2 different groups to get involved in major synthesis efforts to bring together and look and try to synthesize what overlapping constructs are covered across all these theories into a more manageable and useful, hopefully, set of factors that one can use as a basis for identifying barriers and enablers. And so 2 of the most prominent of those frameworks, those synthesizing frameworks, are the Consolidated Framework for Implementation Research, CFIR, or the Theoretical Domains Framework, the TDF. So I'll first start quickly giving an overview of CFIR. So this was developed in the States by Lord Damschroeder and colleagues who synthesized the literature on implementation-focused theories and identified a number of theories and overlapping constructs within them, and brought those together into, nevertheless, 39 different constructs covering 5 overarching categories. Now, this framework covers not only barriers and enablers, but also intervention aspects as well. So just quick, so this is the quite extensive list of factors within the CFIR, and I'm not necessarily expecting us to read through all of these 39 options, but what to focus on are probably 2 things. The first, that there's a particular emphasis on the outer inner setting, or in other words, the broader context in which the behavior is occurring within the organization and out with the organization. And so the CFIR definitely focuses more on those than most frameworks. The other things to focus to highlight is that, as I mentioned, the framework summarizes factors that might act as barriers and enablers in the setting, as well as at the individual level, but it also covers what characteristics the intervention itself might have and how to actually go about implementing that. So it straddles the line between a framework that is used as a basis for barrier and enabler identification with one that might be used to understand the intervention per se, which is effectively what this slide covers. So that's CFIR, just a broad overview of the Consolidated Framework for Implementation Research, but we wanted to drill down on the theoretic domains framework in particular as a basis for identifying barriers and enablers. So the background to the development for this particular framework was that there's a growing recognition in health services research that there is this sort of established many decades of behavioral science about what we know that determines what determines behavior and behavior change across a range of applied settings. And there was a desire to make that literature more useful to those that might be interested in applying it, but that may not necessarily stem from a behavioral science background. And so what the TDF was designed to do is really to address this theoretical model and theory overload, to synthesize key factors associated with behavior and behavior change. And so a group of researchers from Canada and the UK identified 33 predominant theories of behavior and behavior change, covering 128 constructs, and really distilled it down to say that whilst there may be minutiae, splitting hairs, differences between some of these constructs, by and large they're covering 12 overarching domains that can be used as a basis for explaining health-related and healthcare professional-related behaviors. So they did that in 2005. They subsequently repeated that and validated it in 2012, which led to largely the same domains. If anything, 3 were made a little bit more specific and 1 was removed, but largely the same categories, the same domains. And what's useful about this particular framework, at least from our perspective, is that it provides really a list of topics that we can use to explore what factors are known to affect behavior and used as a basis, therefore, for understanding barriers and enablers to behavior change in not only health providers or patients, but also increasingly other higher level actors in the organization, such as policymakers and managers. It's been used as a basis in research for conducting interviews and focus groups with health providers, for example, to understand their views about what helps and hinders, but also increasingly with patients to understand from their perspective and the key behaviors that are involved in their role. And we've done some work to quantify some of this so that it can be used as a basis for surveys or more rapidly assessing some of these factors, and has been used within systematic reviews to, in a sense, re-engineer what interventions we're trying to target to try to understand what barriers and enablers the interventions we're attempting to tackle. And so from our perspective, the advantage of using this particular framework is that, first of all, it's behavior focused. It's applicable to any target, action, context, time, and actor. It covers a breadth of factors that are associated with behavior, some of which we might that won't surprise you. Some of them may be not something that you initially think of, but might be helpful to cover to be comprehensive. And from our perspective, the ability to then link directly to specific strategies and techniques that can be used as a basis for addressing those barriers and enablers, and therefore for designing your eventual intervention, is one of its key strengths relative to some other frameworks. And so this is the list of domains. It's worth saying that some of most of the words are or the domain descriptors are self-explanatory, but some of them have a slightly different meaning. And so Andrea is going to walk us through the definitions of each and some examples as they pertain to hand hygiene. But one potentially useful way of thinking about this is to think about what are, from your perspective, what are the 3 factors needed in criminal law to prove that someone's guilty of a crime? I'll give you 5 seconds to think that through. So it might be argued that capability, you have to be the capability to do it, the opportunity, and the motive. But thinking about those 3 categories, the TDF domains can be broken down into those 3 specific overarching terms, descriptive terms, and I would see them very much as descriptors more than anything, but potentially a helpful way of categorizing the domains themselves. So let's drill down into applying or defining those domains and how they might be relevant to a particular patient safety initiative around understanding the barriers and enablers to using hand gel. So again, we're basing it on having walked through and specifying our behavior using the TACTA. And now I'll hand over to Andrea, who will talk us through the definitions and apply them to hand hygiene.
Thank you, Justin. So basically what I'm going to do is I'm going to provide you with a definition that is reported in the CANE publication in the 2012. But Justin and I have been involved in a number of TDS studies, and we have found that there are slight nuances in the definitions with respect to the CANE paper, and how we've found that it's more helpful to kind of apply a definition that specifically relates to the purpose of the domain, which is identifying factors that influence an individual's behavior. So for example, in the knowledge domain, the CANE definition defines it as existing procedural knowledge or knowledge about guidelines or knowledge about evidence, and also how that may influence what a participant does. So basically it's what does the participant know, or what does the individual know about what they should be doing, and how does that influence what they actually do. So in the case of hand hygiene, the types of questions that you may ask a person if you're trying to find out what are the knowledge barriers or what are the knowledge facilitators to performing hand hygiene. You may ask questions around, do they know the evidence about the need for using hand hygiene? Are they aware about the guidelines around using hand gels or hand gels for hand hygiene? And do they know the 4 moments of hand hygiene behavior? So with respect to skills, it's defined as the ability or proficiency to acquire, or ability or proficiency acquired through process. It's an objective competence and ability about a procedural technique required to perform the behavior. So in, I guess, pseudo-lay terms, it's basically what do they know about how they should be doing something, and how does that influence whether or not they do it or not, or whether or not they do it, sorry. So if we look at the hand hygiene, the types of questions you may want to ask someone may focus, were they ever trained in the proper technique for hand hygiene using hand gels, and has anyone ever evaluated their hand hygiene against recommended steps? With respect to the memory, attention, and decision-making domain, this is defined as the ability to retain information, focus selectively on aspects of the environment, and choose between 2 or more alternatives. So the way that we've defined it is that it can be about their forgetfulness or remembering to do it, and whether that forgetfulness influences whether or not they actually do it. It's also about their ability to focus on the behavior and whether that influences whether they can do it or not. And it's also about their decision-making process through the process of the behavior under investigation. So again, the types of questions one might ask to address this domain would be whether they were aware that they had ever forgotten to do it, and if there were any specific situations where they were more likely to forget. It also can address about taking the time to focus on using the hand gels, and also discussing with them if there are ever instances where they have decided not to do it and what those instances are. Sorry. With respect to behavioral regulation, this is defined as anything aimed at managing or changing objectively observed and measured actions. So it can be existing strategies that individuals have in place to help them perform the behavior, but it can also be those instances where there are strategies that they would like to have in place that may help them perform the behavior. So the types of questions that one might ask regarding hand hygiene were, what existing strategies are already in place to support them, and do they use them? And what additional strategies do they think might help them? And it's important to note that when you're asking about hypotheticals, it's often difficult for them to reflect on the hypothetical. So it's a situation where if you are familiar in the literature or the evidence around it, it may be an opportunity where you should prompt them about ideas that may get them thinking about different strategies not necessarily be aware of. So with respect to environmental context and resources, it's defined as any circumstance of a person's situation or environment that discourages or encourages the development of skills and abilities, independence, social competence, and adaptive behavior. It's quite a thorough definition, but basically this domain focuses on the physical and resource factors in which the behavior is performed, and in the sense it's that context or the setting in which they would do it. This is often the domain that people think of quite quickly when they are asking individuals about barriers and facilitators, because it's the ones around time and resources. So the types of questions one might ask with respect to hand hygiene are what resources do they currently have access to use hand gels in the recommended way, and what aspects of their environment influence whether they can use the hand gel. So with respect to social influences, the definition is those interpersonal processes that can cause individuals to change their thoughts, feelings, or behaviors. It's basically the external influence from other people's views, from other professions, norms, leaderships, can be cultural, and patients and families are also would be found in this domain. And how do those external influences influence whether or not they're able to do what they should be doing? So in the context of hand hygiene, the types of questions one may ask, maybe do other team members influence their use of hand gels, and who would those people be? Do they think there's an expectation that they should be using hand gels? Who are those people that expect them to do it, and how important is that expectation to them? Sorry. The other question you may want to ask, because it's not just health professionals that are involved in healthcare, it's more importantly the patient who receives the healthcare. So it's you can ask questions around how do patients and their families influence their use of hand gels. With respect to belief about capabilities, the definition for this domain is the perceptions about competence, self-efficacy, and confidence in doing the behavior, and it's also their perceived control over engaging in that behavior. With respect to hand hygiene, this is basically about confidence levels. So often you ask questions about how confident are they that they can use sanitizing gels, and it's also about making sure that it's about at all recommended times. So oftentimes people will give you caveats around I'm comfortable using it in this situation, but not necessarily in the other situation. And then the other question that you may want to ask is it up to them whether they can use sanitizing gels in all recommended settings? So moving on. So optimism is one of the newer domains with respect to the second version of the TDF in the Kane publication. And it's defined as a confidence that things will happen for the best or that desired goals will be attained. So overall, it assesses a level of optimism or pessimism an individual may have about whether the engaging in the behavior will result in positive outcomes. So in the context of hand hygiene, often we ask a general question around, are they optimistic that using hand gels will lead to reduced risk of healthcare-associated infections? So they're often quite a broad sort of evaluation of the person's belief in the good of the behavior. The optimism belief about consequences were originally grouped together in the original TDF, but the division was used to create a level about what are the general ideas around performing the behavior versus what do people think will actually happen when I do the behavior. So the belief about consequences definition particularly focuses on the outcomes of behavior in a given situation, its perceptions about the outcomes and the advantages and disadvantages of performing that behavior, or previous experiences that have influenced whether behavior is performed or not. It's basically what are the good and bad things that can happen from what they do, and how does that influence whether they'll do it in the future. So with respect to belief about consequences, we basically ask the questions about what will happen to them, their patients, their colleagues, the organizations if they use hand gels as recommended. And you particularly want to focus on both the positive and negative outcomes and those short-term and long-term outcomes as well. Another type of question one might ask is what will happen if they do not use hand gels as recommended. So reinforcement is defined as the dependent relationship or contingency between the response and a given stimuli. So in the context of hand hygiene, it's about past experiences and how those past experiences may influence whether or not they do it in the future. And also thinking about any external incentives that may be in place that may encourage the hand gel use. So intention, and I think most people are pretty familiar with this one, it's a conscious decision to perform a behavior or a resolve to act in a certain way. But it's also about how inclined individuals are to do something and whether that influences whether they'll do it as well. So often this is very simple yes or no question around whether they intend to use the hand gels and if it's something that they want to do. With respect to goals, it's defined as the mental representation of outcomes or end states that an individual wants to achieve. So that basically means how important is what they do, and does that influence whether or not they do it. So if it's not something that's a huge priority, they're less inclined to actually perform the behavior. So it's about priorities, the importance, and commitment to a certain course of actions or behavior intention. So in the context of hand hygiene, it's using hand gels. Is using hand gels a personal goal, or is it an institutional goal? And another question may be around how much of a priority is using hand gels compared to other competing demands, and which competing demands may interfere with your intention. With respect to social professional role and identity, it's defined as a coherent set of behaviors and displayed personal qualities of an individual in a social or work setting. So it's about whether the behavior is something they're supposed to do, or is it somebody else's role in the context of whether it's the nurses or the health professionals or occupational therapists. And then how does who they are in their profession influence whether or not it's something that they should do. So in the context of hand hygiene, the questions that one might ask would be, is using hand gels part and parcel of how they see themselves as a clinician? And do they see this as part of their job? Or who else's role is it? What are the boundaries between professional groups in who should use hand gels? Emotions are often a domain that people don't necessarily think is relevant to health professionals, but it's important to remember that they're human beings and they have emotions the same as every other human being. And it's defined as a complex reaction pattern involving experiential, behavioral, and physiological elements by which the individual attempts to deal with personal significant matter or events. And so what that means is how their feelings that they may be experiencing affect both positively and negatively influence the behavior that they're expected to do. And in the context of health professionals, it's typically the words that they most often use are around worry or concern, or they also may use terms about I'm happy if we don't have to do this thing, or if we can all get on board with it. Those would be the key language that most health professionals would use around this domain. So a type of question that one might ask with respect to hand hygiene were, how do they feel about using hand gels, and how do those feelings influence what they do? And then you may want to ask them about the absence of the behavior under investigation. So does not using hand gels evoke worry, regret, or concern in them? So I've just, that was the 14 domains, and I just wanted to point out that in this publication around fetal monitoring, which is not related to hand hygiene, we have published adapted definitions for the domains that may make it a little bit easier for people to understand if they choose to use the theoretical domains framework as a way of investigating barriers and enablers to behavior. So, in summary, it's important to recognize that the use of an established theoretical framework provides a strong, replicable basis for identifying barriers and enablers to implementing a patient safety-related behavior. And to reiterate what Justin has said further, it gives you a leg up on factors to consider, and it also prevents reinventing the wheel. It helps to generalize across settings to understand why some strategies may be effective in some settings and some behaviors, but not in others. It can result in findings. Sorry. Oh, I understand now. Sorry. So resulting findings from your barriers and facilitators assessment under each of the domains can then be used to help select the fit-for-purpose techniques and strategies, which will be discussed in webinar 6. My apologies.
Great, thanks, Andrea. So we really thought it would be useful to split almost an overview of the definitions of the theoretical domains framework from examples and tools of how to use it in practice in your own settings, which is what we hope to cover in the next webinar. Based on our experience of even though it's admittedly a little dry to go through some of these definitions, it's useful, we hope, as a go-to tool that you can use to quickly remind yourselves of what the different domains are, what the definitions are, and how they might apply, at least to hand hygiene, so that that provides the foundation with which we can provide hopefully some helpful tools in the next webinar. So as always, in the meantime, if hand hygiene doesn't speak to you particularly, we're happy to incorporate other examples as we go through the remaining webinars, so please do send them my way. But short of that, thanks very much again for your time and your attention, and we'll do our best to answer any questions that you have now or via email. Thank you.
Fantastic. Thanks so much, Justin, and thank you, Andrea. The presentation was fantastic. I actually asked Gina Peck to capture that slide number 60 so that we can send that request off to our participants, just to remind them in the email to supply ongoing patient safety initiatives so that they can send them your way and perhaps get folded into the next webinar. I have to say that I was delighted about the example you guys used, since Stop Clean Your Hands Day is on Friday. So really, thank you so much for all that preparation and preview there. So
we absolutely planned it that way.
Yep. Well, and it shows your preparation was stellar. So we have received a few questions from the chat box. So if I may start, question 1 was, are there tools we can access that would assist in developing the interview questions? The ones you specified as being needing to define the barriers and understand the potential solutions, and maybe following that, how do you ask these questions? Do you survey the publics? Do you ask them right at the spot of service, et cetera? Can you tell us sort of how to develop and then how to ask?
Yeah, fantastic question, and we won't. That's very much what we hope to cover in the next webinar.
Oh, gotcha. I'm sorry if I'm spilling the beans early.
Yeah, no, but the short answer to that is. There are a range of different methodological approaches that you can use, for example, interviews, focus groups, surveys, and there are, what we'll present next time are published examples and examples in development of actual tools that you can use as a basis for adapting it to your particular setting or your particular TACT-specified behavior.
Fantastic. Andrea, did you have something to add?
So I will say that this framework has been in existence for 13 years now, and it was only last year that a recent publication came out around. I think it's by Lou Akins, A-T-K-I-N-S, published in Implementation Science in 2017. It provides kind of like a general overview on how to do a TDF study about barriers and facilitators assessment, and as Justin said, we're going to use that kind of as the platform for the end of the month, I think. Is it May 20th? Yeah, so we're going to use that with practical examples.
Perfect.
So
do you want to hold off on that so that we just give them a little taste and demand that they come back to us on May 30th?
Yeah.
Perfect. So that was the teaser campaign. Excellent. I have a second question that came up here. As theories address fundamentals, it would be helpful to research both knowledge and implementation strategies to understand how does one extrapolate insights from the hand hygiene example to behavioral aspects of all stakeholders, policymakers, practitioners, and patients related to other critical safety matters such as, say, end-of-life care?
That is such a good point. And so in relation to that, we're, for better or worse, embarking on a systematic review of all existing TDF studies that have been published. And Andrea and I had a going bet to say, is it going to be over or under 100? And it's probably well over 200 now that we're at. And one of the purposes of conducting that, beyond highlighting how often this framework, or how useful potentially this framework might be across settings, is that we can hopefully start to draw lines across different areas, clinical areas, to see whether is there consistency in a particular domain, irrespective of the behavior or setting, or the particular unique settings and circumstances for which there's a particular set of domains that are really coming through. And now that we have this massive amount of existing literature to base on, we should be able to hopefully in the next few months answer that question more directly with regards to how specific applications, for example, of hand hygiene might generalize to what might seem at the face of it quite different kind of life care, but at the end of the day, it involves behavior change as well. Again, hold that thought, and we hope to have at least some early results of that systematic review within the next few months.
Fantastic. Andrea?
So I think to reiterate Justin's comment of I won the bet, and I think one of the things that you can kind of take a look at when designing these sorts of evaluations is the methods are applicable in if not all contexts, then most of them. And I think it's important to think about your TACTA. So if your TACTA becomes more complex, then your investigation is going to become more complex. But it's often, if it's an individual or if it's a team of individuals, they're working in a relatively closed setting. I mean, it's a chaotic and complex setting, but it's a closed setting. So one could infer that a lot of the challenges to doing a relatively simple behavior of hand hygiene would be the similar domains. They might not necessarily be specific in the content within those domains around, end of life care, but those groupings of domains or the barriers and facilitators within a domain, while being different, the domains may be similar. But as Justin said, it is interesting to see what our findings are with respect to the systematic review, and I'm actually quite nerdedly excited about it.
Perfect. So the steps that you go through are relatively similar regardless of what the actual field of inquiry is about. So I think that extrapolation hopefully will be proven to be quite clear. I have question 3 from Susan.
Yeah.
You said that the TDF framework is appropriate for safety initiatives. Is it equally applicable to quality initiatives?
As long as you can define the behavior of someone that needs to change to implement the safety initiative or the quality initiative, then absolutely. I think that's the fundamental basis of the utility of this framework is it's based on the assumption that someone needs to do something differently in order to improve care in this case. And as long as you can pin down at least one behavior, it's usually more than one behavior, usually more than one person. But as long as there's a behavioral, something that you can break down the behavior into, then absolutely it applies to quality.
Excellent. Excellent.
And even at a systems level, it's still a bunch of people in a room making a decision around something.
That's right.
So it's still about an individual deciding to do something differently than what they did a couple of days ago. So it's still that aspect of a behavior needs to change or adjust or whatever. Or even if it's one behavior or even if it's one person doing one behavior or multiple people doing multiple behaviors, the TDF can be applied to investigate that. It gets a little murkier. Mm-hmm. So there is that caveat, but it's still better than just sitting in a room trying to figure out what to do without people.
Yep, I will take your word for that for sure. I have a question from Diana here. In your experience, would you ask the target group about all the domains, or would you focus on some in particular for any particular target group?
Yeah, so that's a good question. We tend to advocate covering them all, at least in the first instance, if it's the first attempt that you're covering this. It's usually on the basis that we might have assumptions about what is relevant, and they may be confirmed by our however we decide to ask those questions. But I often find that I'm surprised with what comes through regardless of my previous assumptions. And so, at least, like I say, at least for the first few conversations or surveys or however you want to collect the data with your target audience, I would advocate covering all of them. That has its potential challenges in terms of the time it takes to collect the data, and that's something we'll cover in the next webinar, the different options depending on the availabilities of your target audience as well. Yeah.
Great, yeah. So, sorry, go ahead.
I said I have nothing to add. That's exactly
okay, great.
You want confirmation.
So after that fact, if you do find that you have an issue with one domain, are there recommendations on how to leverage other domains to mitigate those issues, those outstanding problems?
So you're scratching at the surface of the where the TDF is going next. I think is once you because the TDF is effectively a synthesis of pre-existing theories. One option that I think is kind of at the cusp of the current implementation science is how do you then potentially select a more specific theory to drill down to cover that. So, for example, if you found that confidence was a major issue in some of your, for hand hygiene, that's probably not the case, but for another element, there might be some sort of, the recipients might not feel that they're self-efficacious in being able to do the behavior, and that seems to be the biggest barrier. And by flagging that highlights, you can have a look at existing theories that allow us to understand not only confidence and self-efficacy, but what drives confidence and self-efficacy and what are the other domains that are relevant for that. And that's sort of work in progress as to, for those that may want to drill down into more detail on a given domain in that way. That, like I say, Andrea and I are working on that.
Excellent. Well, thank you. I have another question specifically about domains. Do you have advice as to how to scale the answers? The example given was staff believe that hand hygiene is important, but primarily only focus on moments 2 and 3. Moments 1 and 4 are believed to be excessive. How would you scale the answers that are given that way?
Yeah, good questions. And by scale, you mean generalized to the other 2?
Yeah, or emphasize the importance or focus on the actual actions that need to be taken to change behavior.
So if it's a series of steps and if you've done this a number of times and everybody everybody that you've talked to or you've done questionnaires with or you've done focus groups with, if they are in accordance with saying, you know, I can't remember the numbers, I'm sorry, like say 2 and 3 are not a problem, but 1 and 4 are big issues for us, then you can say, okay, well then it's obvious that we need to focus a bit more detail on how to improve 1 and 4 if 2 and 3 are not a problem. So it's okay to narrow the focus.
De-emphasize?
If during your investigation you find that there are certain things that are a bigger issue than others. And that can be on any component within the TACTA. So I've been involved in 2 separate studies, one where we interviewed 1 actor, and then about 4 interviews in, I discovered that there was another actor that was involved that I wasn't aware of in my lit review, and I was kind of like, holy cow, I've now got to go and try to talk to these people because they're involved. And another instance, so that was a variation in the actor. So that we ended up expanding the actors involved. But within another evaluation of a decision rule, there's 4 steps in the decision rule, and it seemed that everybody seemed to be okay with 3 of the 4 steps within the decision rule, but it was this 4th one that seemed that they were unsure about, or they were uncomfortable, or they weren't confident in their ability to evaluate this 3rd step, that just kind of skewed them to doing what they weren't supposed to be doing. So we then identified that as the bigger problem, and that kind of allowed us to focus developing an intervention on that specific problem rather than the whole decision rule.
Perfect.
So it's okay to, if you've got evidence to support that it's 1 or 2 things, then it's okay to focus on those 1 or 2 things. That's the point of doing the barriers and facilitators assessment.
In some ways, what I would add to that is that it's a lovely example for how even within an overarching behavior like hand hygiene, there are sub-behaviors for which there are different domains that are different types of barriers and enablers. So for 1 and 4, the way unpacking why it's perceived as excessive. So clearly they're not motivated to do it. It may be a time issue. It might be beliefs about consequences not worth doing. Those are different barriers than the other 2 and 3, for which they're feeling motivated and they want to do it, but perhaps may not be doing it as well. And there are other barriers for that. So for me, it's almost a neat example, even within hand hygiene, to say that by unpacking the barriers underlying each of them, that might provide different types of solutions that you might want to take forward to intervene for the case of 1 and 4, try to find ways of increasing the perceived importance or intention versus 2 and 3 to address any other barriers that might stop them from following through with their nevertheless good intentions.
Perfect. Perfect. Well, thank you, Justin. Thank you, Andrea. I have one more question that came from the floor. I guess we don't really have a floor in a webinar, but this may be related to the upcoming webinar, but should we use all of the domains of TDF when looking at the barriers and facilitators, or should we select the domains that appear to be the most appropriate for our context? You did mention earlier, Justin, that you believe to run through the entire thing, but if you believe you know what the most appropriate are for your context, should you select those ones or do the entire process anyway?
My gut reaction to that is that even when, in my experience, what I believe to be important might be confirmed, which is important, but it could be that covering all 14 flags something that you may not realize is important, and just in the way that you prompt people and you collect those data, it flags something that isn't on your radar, and that in some ways is the most exciting way of doing it, because it potentially leads you down a path of something new that you might focus on to make a change. And so I think from my initial feeling on that, like I said before, is there are a lot of advantages of covering all of them, at least in the first few times that you interrogate the particular behavior and the people that are engaged in it.
Perfect. Thanks so much, Justin. All right. And I guess I'll just entertain one more before I sign us off. Is there a publication or book on knowledge transfer or implementation science that you can recommend just off the top of your head besides ones that you've published, or maybe even mentions ones you've published?
So with respect to the TDF, the theoretical domain framework that we covered, the seminal papers by Susan Mickey, 2005, BMJ Quality and Safety in Healthcare, as it was called at the time. It's probably the first one. It's a relatively short paper and a good overview. I wouldn't necessarily say Kane 2012 is an initial go-to. It's a bit dense, but it provides all the definitions in detail. But if you're talking about KT and implementation science in general, off the top of my head, there's a couple. So there's Canadian ones by Sharon Strauss, Ian Graham, and others. There are U.S.-led ones by Ross Bronson, and UK based ones led by Martin Eccles and Richard Grohl. But the names of the titles of the books I can't unfortunately remember off the top of my head. But I'm happy.
We can look up those authors for sure. So.
Yeah. I don't know, Andrea, if you remember.
Andrea, anything pop to mind for you?
So I think the Martin Eccles, Richard Grohl one is about patients. No, I'm not going to say anything. Whatever I say is going to be completely off the top of my head, so I will.
Not a problem. Okay, well, thank you both so much. Oops. Sorry, go ahead.
We'll make a point in the next webinar to flag those resources.
Oh, that'd be great, yeah.
At the beginning.
Yeah.
Sure, terrific. Well, thank you both so much. I see that we are at time, though, so we want to respectfully thank Drs. Proceau and Patey for sharing your time and experience and expertise. And thanks, of course, to all of you for taking the time to attend. We know how busy your day is, and we appreciate you choosing to spend time with the Canadian Patient Safety Institute. And note that the hand hygiene discussion we enjoyed in this webinar can be explored further on Friday's Stop Clean Your Hand Day webinar, featuring Ms. Lori Moore and Dr. Benedetta Allegranzi. Visit the CPSI website for details. Please visit our website as well for a taped version of the presentation today and to sign up for our next Knowledge Translation and Implementation Science webinar. On May 30th, we will welcome back Drs. Proceau and Patey to take this discussion another step further on providing concrete approaches for identifying barriers and enablers, emphasizing behavior change approaches. If you wish to sign up for the upcoming webinar, or if you want to continue the conversation started in this discussion, please feel free to send us an email. We will forward your comments and any questions you may have had that were unaddressed to Drs. Proceau and Patey. You should all receive Gina Peck's follow-up thank you email in your inbox shortly, and you can respond to that. Have a wonderful day, everyone, and we will really hope to see you again soon.
Thanks so much.
Thank you.
Thank you again.